Welcome back, coders. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. I'm absolutely thrilled you're here, because today we are tackling part 62 of our 100-part CPC exam series. We're diving headfirst into the Medicine CPT Masterclass. Now this section, it's notoriously rule-heavy. We're talking complex component billing, but honestly, by the end of this explainer, you're going to navigate it like an absolute pro.
So here's today's CPC Masterclass agenda. We're exposing the top exam traps in immunizations, infusions, cardiovascular, and dialysis coding. Oh, and definitely stick around for a visual cheat sheet at the very end.
Section 1. Medicine Section Overview.
Okay, let's lay down our foundation. The Medicine CPT section spans from code 90281 all the way up to 99607. It is literally massive. It covers this huge, broad range of non-invasive or minimally invasive diagnostic, therapeutic, and preventative medical services. But here's what's absolutely crucial for you to know. This section heavily tests two main concepts. First, component billing, which basically means breaking a service down into its technical and professional parts. And second, who did what? You've constantly got to ask yourself, right? Did the physician do the whole shebang, or was the work split up?
Section 2. Case 1. Immunization rules.
All right, imagine a classic exam favorite. A 4-year-old gets an MMR vaccine and the physician provides counseling. Later on, they get a flu shot, but this time, zero counseling. So how do we actually code this? Well, it's strictly divided based on age and counseling. For our 4-year-old getting the MMR with that physician counseling, we use code 90460 for the first component. Then we add on 90461 for any additional components in that combination vaccine. But for that flu shot where no counseling was documented, or say if the patient was an adult, we completely shift gears. We use the route-based 90471 family instead. Seriously, if counseling isn't clearly documented in the vignette, do not just assume it happened.
And this perfectly illustrates the absolute most important rule of immunizations, the dual coding mandate. You must always code both the administration code and the specific vaccine product code together. The product code is not the administration code. The exam fully expects you to report both of these, unless the scenario specifically mentions the vaccine product was free or supplied differently.
Section 3. Case 2. Injections and infusions. So, moving right into the 96360 to 96379 range, the crucial thing to grasp here is the infusion hierarchy rule. When multiple types of infusions happen in a single visit, you have to code the highest level service as the primary, initial code. Chemotherapy is king here. It completely trumps therapeutic infusions, which in turn trump hydration. Remember, you can only report one initial code per encounter unless, of course, you have completely separate IV sites established. Everything else, it just gets an add-on code.
Now here's a major exam trap you'll definitely want to circle in red: hydration. To actually bill hydration codes 96360 or 96361, it must be clinically indicated and it has to run for a minimum of 31 minutes. If it runs for exactly 30 minutes, no way, you can't bill it. Also, and this is a huge trick they play, if the hydration fluid is merely being used to flush a line or just act as a vehicle for a drug, it is absolutely not separately billable. Don't fall for that one.
You also really need to know the strict time thresholds that separate a push from an infusion. An intravenous push is strictly defined as 15 minutes or less. The split second that clock ticks over 15 minutes, boom, you are officially in infusion territory. You've got to keep a super close eye on those documented start and stop times in your exam vignettes.
Section 4. Case 3. Cardiovascular coding.
Let's look at some non-invasive and minimally invasive diagnostic procedures next. For diagnostic cardiac catheterizations, your code selection strictly depends on the vessel approach. You have to ask, did they go into the right heart, the left heart, or was it a combined right and left approach? On top of that, you always have to verify if coronary angiography or injection procedures were included, because those specific details will push you straight into very specific combination codes in the 93451 to 93461 range.
When it comes to echocardiography, there's a massive trap waiting for you with code 93306 for a complete transthoracic echo. That base code actually already includes spectral and color Doppler, so please do not stack separate Doppler add-on codes on top of it. You only ever use those add-ons if the base code descriptor specifically says it's without Doppler.
And this brings us straight to Holter monitoring and component splitting.
Remember when I mentioned who did what earlier in this explainer? This is exactly what I meant. If one doctor's office does the whole 24-hour thing, you just build a global code, 93224. But say the facility just does the recording, that's 93225. If they just do the analysis, it's 93226. And if a physician is just reading the report from some other facility, they build a professional component, 93227. You need to know this split code for the exam.
Section 5, Case 4, Dialysis and Ophthalmic. Okay, let's tackle our final set of cases, starting with end-stage renal disease, or ESRD. Outpatient monthly capitation payment codes are driven by exactly two factors. First, the patient's age. Second, the exact frequency of face-to-face physician visits that month. A patient seen 4 times gets a completely different code than a patient seen 2 times, so make sure you count those visits very carefully in your exam questions.
As for general ophthalmic exams, your code selection hinges entirely on whether the exam is intermediate or comprehensive, and of course, whether the patient is new or established. It's a very specific matrix in the 9200 series, so you'll want to follow those definitions super closely.
Section 6, Part 62, Visual Cheat Sheet. Wow, we've covered a lot of ground today, so get your screenshot fingers ready. Here is your visual cheat sheet. Let's lock all this in. For immunizations, dual code the admin and the product. For infusions, obey the chemo, therapeutic, and hydration hierarchy. Cardiac caths are coded by approach. Holter monitors are split by component. And finally, ESRD dialysis codes demand patient age plus the monthly visit count. These right here are your absolute golden rules for the medicine section.
So, now that we have CPT largely behind us, you kind of have to ask yourself, are you ready to conquer the final frontier of coding?
Because that is exactly what we're doing next time. In Part 63, we are diving deep into the HCPCS Level 2 Coding Masterclass. We're going to be decoding A codes all the way through V codes, mastering those tricky modifiers, and navigating the ins and outs of Medicare guidelines. Keep up this incredible momentum, keep studying hard, and I will see you in the next explainer to continue acing this CPC exam.